The compliance of the lungs is a measure of how easily the lungs expand, and internal structures of the lungs will affect this. And like Goldilocks, right, you want to have a typical lung compliance. If you lose a lot of the supporting connective tissue around your alveoli, you can increase compliance, and that's not necessarily good, right? It makes it hard to have your lungs that will snap back, and we'll talk about that in a moment. But you also don't want to have a lack of compliance. So if you have inadequate surfactant production, for instance, then the sides of the alveoli stick together, right? Because that water creates a vacuum because of surface tension, and it's much harder to open up those alveoli. So you have much lower lung compliance, and this makes it much harder to breathe. Also important and related is resistance. And this is a measure of how difficult it is for air to flow through your bronchioles, essentially, into your lungs. And so increased resistance can result from inflammation or bronchoconstriction if you're having an asthma attack or something like that. Inflammation, if you have bronchitis, things like that. It narrows those tubes and makes it harder for you to breathe. Increased resistance to flow, just like in your blood vessels when you have a narrower diameter. Your sympathetic nervous division will stimulate bronchodilation, which decreases your resistance and allows you to get even more air into your lungs. This is why you might take some bronchodilators if you're having an asthma attack, or if you're having an allergic reaction or something. You might take epinephrine, which will have a sympathetic response. And this discussion of resistance brings me to COPD, chronic obstructive pulmonary disease. There are three types of COPD. The first one you're probably familiar with. It's asthma. Asthmatic bronchitis is another way to put that. But essentially, this is when you have intermittent but acute symptoms, meaning you don't always have issues with asthma, but when you do, it's acute. It's an attack, right? And it causes your bronchioles, your conducting passageways, to become irritated and to constrict and become inflamed. And these irritants can be allergies, toxins, even excessive exercise, things like that. And so if you have asthma, you can have these, intermittent acute attacks that will obstruct your bronchioles. Our second example of COPD is chronic bronchitis. Now, a lot of us get bronchitis or inflammation and swelling of the bronchial lining from time to time, right? You get a bacterial infection or a viral infection, and it swells up, and usually it's bacterial infection. You take some antibiotics and it goes away. But some people have just long-term inflammation of these bronchial linings, and this increases resistance, and this makes it a lot harder to breathe. The most common cause of this is cigarette smoking over a long period of time. This can lead to relatively low oxygen levels, which can impact your metabolism and energy level, and it also can lead sometimes to heart failure, which can cause edema and swelling in lots of places in your body. So the third example of COPD, which is typically what I think of when I think of COPD, is emphysema. And emphysema is a chronic progressive condition, meaning it doesn't get better. You can only slow it from getting worse. And it is the destruction of your alveoli, essentially. So instead of having lots of tiny alveoli, you have fewer larger alveoli because they've been destroyed and sort of just become these larger air sacs. And larger air sacs doesn't sound bad, but what it means is you have much less surface area for exchange than you would if you had lots of tiny air sacs. And if you have less surface area, you have less exchange, you're getting less oxygen per breath into your blood, and you're also getting less CO2 per breath out of your lungs. So not only are you having trouble getting oxygen in, but even if you're on oxygen, right, you've got an oxygen mask, and you're increasing the concentration difference between what's in your lungs and what's in your blood, so you're actually getting enough oxygen in maybe. You're not getting enough CO2 out, and CO2 makes your blood acidic, and that's how your brain sort of assesses whether you have enough oxygen, is really pH and CO2 level. And so you may be getting enough oxygen, but your blood is acidic and you feel like you need to take a breath, right? So you have this shortness of breath feeling. Here you can see an x-ray of someone with emphysema. Emphysema is also frequently caused by smoking or sometimes by environmental irritants, or if you work in a factory or in a coal mine where you have a lot of environmental irritants that could damage your lungs. Control of your breathing rate is important to survival, and that's true not just of humans, but of lots and lots of our evolutionary cousins and ancestors. And so it's wired in, the places that control it, to our brain stem, right? Not to our higher up, more recently evolved cerebral cortex, but the most basic level of control involves pacemaker cells in your medulla oblongata that dictate the typical rate of breathing for you. And within your medulla oblongata, you have a dorsal respiratory group, which is essentially setting your basic breathing rate in response to feedback from oxygen, CO2, and pH levels in your blood and in your cerebrospinal fluid that tell you, yes, we've got a normal amount of oxygen. Our blood is not too acidic because of excess CO2. And this is what stimulates our primary inspiratory muscles, like our external intercostals and our diaphragm, right? And these cause us to breathe normally. And below that, you have a ventral respiratory group, which stimulates your accessory respiratory muscles in case you have to do some extra heavy breathing. Now, if the medulla oblongata is where your typical breathing rate is set, right, and your signals to breathe in and then relax and breathe in and relax are sent, the pons is where you adjust that breathing rate up or down based on feedback, again, about blood oxygen levels, blood CO2 levels, blood pH, things like that. And your Apneustic center is the portion of your pons that stimulates deeper, longer breaths, whereas the pneumotaxic center is going to stimulate shorter breaths and sometimes faster breaths. But while your hypothalamus tends to set your typical breathing rate and your pons tend to adjust that typical breathing rate, you also can get some feedback from higher centers like your limbic system and your cerebral cortex. Your limbic system is sort of your emotional center and your desire and aversion center. And so we know that things can get your blood boiling, can make you breathe heavier. It's 2020 and I don't know about you, but I just watched that debate the other night and my limbic system was going and it caused my breathing to change. But in addition to your limbic system, you also have your cerebral cortex, and this is where you have conscious, voluntary control over your breathing. So no matter what's going on in terms of your blood oxygen or CO2 or your emotional state, you can just consciously tell yourself to breathe in and breathe out. And it tends to take over executive command from the rest of those deeper brain functions. In addition to feedback based on chemoreceptors, meaning detecting chemicals like oxygen and CO2 and pH, hydrogen ions in your blood, to affect your breathing rate, you also have baroreceptor reflexes, just like you do for your heart rate. Baroreceptors, again, meaning pressure, stretch receptors. And your baroreceptors can detect high blood pressure or low blood pressure. And if you have a drop in arterial blood pressure, you're not just going to want to crank up your heart rate, which you do. We already talked about that in the last couple chapters. But you're also going to want to increase your breathing rate, because if you're not getting as much blood to your tissues, you want to make sure that the blood you are getting to those tissues is full of oxygen. And so a drop in arterial blood pressure will mean an increase based on a reflex of your respiratory minute volume, of your breathing rate. You're going to breathe more frequently. You're going to breathe deeper. An increase in arterial blood pressure will inhibit those respiratory centers and cause you to slow down your breathing and to breathe more shallowly. And these go back and forth almost like a seesaw, right? As your arterial blood pressure drops, your respiratory minute volume goes up to make up for that lack of blood flow. As your arterial pressure goes up, your respiratory minute volume is going to go down because you may not need quite as much oxygen in your blood. Now, as with most of your other body systems, as you get older, this one stops working as well, right? Your respiratory system. And it does that partially because your elastic tissue begins to break down. And so that means that you don't have that snap back of your lungs to exhale as easily. Your vital capacity is going to go down. People develop arthritis all over your body, so that happens in your ribs too, and that makes it harder to breathe, right? You have less compliance to breathe out. And everyone gets some degree of emphysema, right? The breakdown of those alveoli from lots of little alveoli into smaller, larger ones. Because we all get exposed to various irritants along the way. But some people, the more irritants you get exposed to, and especially if you're a smoker, this is going to occur more. And this is a look at how your respiratory performance comes down as compared to your performance at age 25 when you're kind of at your peak. If you've never even smoked, for instance, you're still going to drop down to maybe 65% of your performance by the time you get to your 80s, right? You're not going to be running marathons as much. If you're a smoker, you can see it drop a lot faster, right? What you would be in your 80s, you are, in your 50s if you're a smoker regularly, right? Again, starting at about age 25. At this point, we hit a level that's disabling, and at this point, we hit death, right? You can't survive at this point. So this is an average, right? Not everybody has the same curve, but this is an average. But notice that if you stop, right, for instance, when you're 45 or so, then your curve changes, right? And it makes a big difference, right? So this is going to be part of my little anti-smoking PSA during your respiratory system chapter. And remember, this has nothing to do with cancer. We'll talk about that in a second. This is just your respiratory performance, based on things like emphysema. Lung cancer itself causes more deaths per year than any other kind of cancer. More people than colon cancer, breast cancer, and prostate cancer combined. And these are a few years old, so they may not be exactly up to date. But as of a few years ago, half of lung cancer patients were dead within a year of diagnosis. So this is serious, and almost 90% of lung cancer cases are directly related to cigarette smoking. Not all of them, but awful darn close. And this is a look at incidence of lung cancer per 100,000 people. As you can see, through the mid-2000s, this was growing for women and dropping for men, but males are still more likely to get it. Males are also more likely to smoke than females. And smoking rates, since these numbers have come out, have dropped, but vaping has gone up significantly. And this is what the process looks like, how smoking affects your cells. So the chemicals and carcinogens in the cigarette smoke and the nicotine come in, and they irritate these cells. And the carcinogens actually cause there to be DNA mutations. But this irritation causes more mucus production, and it arrests your cilia, so you're not able to push up that mucus. And so when you can't push up the mucus, the only way you can get that dirty, crappy mucus out of your lungs is right, that terrible smoker's cough that you're probably familiar with. This happens during dysplasia. And then eventually, just almost like you form calluses on your fingers, right? You form these extra cells here. This is called metaplasia. And at this point, we're still reversible, right? If you stop smoking, you can go back from this. This is not cancer. But eventually, this can cause out-of-control cell growth, and that's when you get a tumor. And this is cancer. And sometimes that cancer can metastasize and move to other parts of your body as well. So this is where we get into neoplasia and then anaplasia, which is where you have cancerous tumors here that can metastasize. All this to say, smoking's bad for your health.